Hello, and welcome to another great AFM tutorial. In this tutorial series on clinical guidance during the COVID-19 pandemic, AFM aims to provide clinical resources on the management of COVID-19 disease with a focus on low-resource settings. However, please keep in mind that clinical guidance does not replace bedside decision-making, and all guidance here should be adapted to your local setting and to the patient in front of you. The first and most essential step to implementing any successful project is planning. Planning must be done with your local setting and facility layout in mind. The process must be thought through carefully from the point of view of the patient, as he or she will experience the process. Detail and evolve this plan by involving all relevant stakeholders, from hospital management to doctors and nurses to cleaning and clerical staff. Ironing out as much wrinkles as possible in the planning stage means that it won't be too difficult to troubleshoot in the implementation phase. This can be done with the aid of a process map, which we will talk about shortly. Try to keep the patient flow as unidirectional or as one way as possible, and keep in mind that a suspected COVID patient may have to transit from one location to another within the facility, and attempt to keep these COVID patient pathways from intersecting with the non-COVID patient pathways as much as that is possible. Once the mapping and planning is done, do a physical walkthrough to see if there are any missing steps. In the video we watched earlier, you saw that there were certain things that are needed for the process of screening. Can you think of what those are? I will give you a moment to list them mentally. We can think of things that are needed for any process in the EU as space, or the actual physical area in which the process will occur, staff, or the equipment that will be needed, which can be as complicated as medical equipment or as simple as stationery. The staff, or the workers who will perform the process. This includes both clinical staff, like doctors and nurses, as well as non-clinical staff, like cleaners and security. And tasks, or the sub-processes that when put all together achieve the overall process objective. Let's look at these with regards to screening. First, identify the space needed for screening. This should ideally be located outside the facility, close to the entrance of the hospital and emergency unit. Clear signage in local languages should direct patients to come to the screening station before entering the facility. The space could be as simple as a desk and a chair placed outside the entrance, or even a tent. Whatever it is, it should be well ventilated and ideally offer privacy and protection from the elements. The staff who are screening could be a junior clinician, a nursing assistant, or a junior doctor. The staff should be trained to screen and have a written protocol to work from, including a mechanism to alert a senior clinician in case of uncertainty. The staff should be rostered such that screening occurs 24/7. Screening will not work if it is only done for part of the time, and the roster should factor in breaks and off time for staff wellness. Non-clinical staff, such as cleaners who clean and sanitize the area, as well as security personnel, may be needed as well, depending on the layout of your facility. Check that your staffing levels are feasible to maintain patient separation and flow, and talk with hospital management about staffing needs and reassignments. The stuff or equipment needed for screening. Even for such a seemingly simple process as screening, equipment is needed. A desk, chair, and PPE for staff, an electronic or hard copy of the protocol for screening, including the updated case definition, masks for patients and hand sanitizer, or facility for hand hygiene with soap and clean water. Stationery could include a pre-written sheet with tick boxes. Avoid having the patient handle the documents or case file to avoid contact spread. The tasks. The staff member could question the person being screened against the updated case definition, and if the case definition is met, should give and demonstrate how to apply a face mask to the patient, if she or he does not already have one. The staff member should direct the screened positive patient to the COVID triage area of the EU and the screened negative person to the non-COVID EU triage area. Clear signage should also direct the patient to these respective areas. Here is an example of a flow diagram depicting how the screening and cohorting processes fit in within an EU. I will give you a few moments to have a look at it before we get into the details. Screening directs people into two arms, a high risk for having COVID arm and a low risk for having COVID arm. Let's take a closer look at the low risk for having COVID-19 pathway first. For people entering the facility who screen negative or who are low risk for having COVID-19 disease, they are directed via the normal or pre-existing local policies to the non-COVID EU. Although some people entering the hospital may not be patients, that is, they may be visitors or have other business at the hospital, AFIM advises that during the COVID-19 pandemic, visitors to the hospital be restricted as far as is possible. No visitors should accompany patients into the hospital if it is at all avoidable. For patients that screen negative, they should be directed to the area of the emergency unit designated to manage patients at low risk of having COVID-19 disease and be triaged as per local protocol. It is very important to note that although screening directs patients into risk categories for having COVID-19, that patients may access care for non-respiratory complaints such as motor vehicle accidents, but still be infected with COVID-19. In other words, any EU patient may be incidentally infected, and all areas of the EU are at some risk of SARS-CoV-2 exposure. Appropriate precautions at the local level should be taken to guard against this as much as is possible. Okay, so let's move on to the patients who screen positive and are at high risk for having COVID-19. Patients who are screened positive should be given and shown how to apply a face mask if they do not already have one on. They should then be directed by screening staff member and clear signage to the COVID EU area. The COVID EU area should contain a triage area separate from the non-COVID triage area in which screened positive patients are triaged according to local protocol. In settings where a validated triage tool is not yet in use, AFIM recommends using the WHO Interagency Triage Tool. An upcoming tutorial will provide detailed training on the WHO Interagency Triage Tool, but a few points on triage will follow after this slide. Those patients that are triaged as low priority may await further management in a designated waiting room for suspected COVID patients. Those patients who are triaged as higher priority should receive care immediately if they are triaged as emergent or needing immediate resuscitation. This should be preferentially done in a designated resuscitation area, which should be separate from the non-COVID EU resuscitation area. Patients triaged as higher priority but not needing immediate resuscitation may be transferred to a COVID EU treatment area, in which they should receive care as soon as is possible. Here are just a few points specific to COVID triage. Triage prioritizes patients so that those who need care quickly are seen and treated sooner. During the COVID pandemic, the following triage observations are recommended at a minimum. Triage observations should include respiratory rate, oxygen saturations, if available with a portable and easily sanitized probe, pulse rate, temperature, preferably with a no-touch thermometer, and a mobility assessment, which includes whether a patient is able to walk by themselves, needs help to walk, or is unable to walk at all. Due to the risk of spread of the virus, the triage area should be well ventilated and distinct from the non-COVID triage area. Medical equipment, for example the oxygen saturation probe, should be disinfected after each patient use. Medical equipment for triage should not be used, if possible, for patients who are not suspected of having COVID-19. Proxy assessment of blood pressure by palpating the pulse for volume and character and by observing the skin perfusion may be used unless there is a concern for low blood pressure or the patient has a history of hypertension. In such instances, blood pressure measurement may be performed and the BP cuff cleaned and sanitized after use. During this talk, I have mentioned the COVID emergency unit area a few times. But what is this and how and why should this be implemented? The picture above shows a typical EU or emergency unit layout with an area for resuscitation, treatment, a waiting and triage area, as well as an administration area for patient registration. While it is ideal to have a separate COVID EU area that would mirror the non-COVID EU area with a separate resuscitation, treatment, triage, and waiting area, this may not be realistic for many settings. While it is out of the scope of this tutorial to go through the finer details of setting up a COVID EU area to maintain patient separation and cohorting, we will briefly touch on a few points regarding the COVID EU setup. We will use a similar model to when we thought about the screening process of space, stuff, staff, and tasks. The COVID EU area should be physically distinct or separate from the normal EU, ideally with no air circulating to the non-COVID areas of the hospital. This may not be achievable in many EUs, however, and as a last resort, the COVID EU area should have clear demarcation, with, at the minimum, a soft barrier such as curtains separating from the main EU area. This would not be ideal, but may be the reality for many facilities with limited space and resources. Just like the normal EU, the COVID EU should be close to the entrance of the facility, the screening station, and the important ancillary areas like the lab, pharmacy, radiology department, and morgue. The COVID EU area should be well ventilated with as many open windows as possible. Ideally, there should be a distinct path to the COVID EU from the screening station with clear signage. A PPE donning and doffing area for staff should be located just outside the entrance of the COVID EU, and the entrance should be access controlled. Designate separate sub-areas within the COVID EU for triage, treatment, resuscitation, and a waiting room. Don't forget about the non-clinical areas such as bathrooms and a writing station for staff, etc. You should go through the space, staff, and tasks planning method for each of these sub-areas. For the purposes of this video, we will not go through each step for each area except to highlight a few important points. When it comes to staffing the EU, take into account both clinical and non-clinical staff, such as kitchen staff, security personnel, cleaning staff, as well as doctors and nurses. As far as possible, minimize contact between non-clinical staff and patients. For example, security can be stationed directly outside the area instead of within, and clerks registering patients can do this verbally such that no paperwork is passed between them. This area will need to function 24/7, and staff will need to be rostered to provide continuous care and should be geared towards staff wellness. You may consult the link provided for guidance on adequate staffing numbers and engage with hospital management with regards to staffing requirements and staff reassignments. All staff, including non-clinical staff working within the COVID EU area, must be trained in and provided with adequate PPE. Without going into too much detail, equip the COVID EU area with a focus on respiratory illness. For example, stock a larger proportion of oxygen delivery devices. Any equipment used in the COVID EU should preferably not be transferred out of the area. If it must be done, ensure IPC practices and adequate disinfection. PPE and hand hygiene facilities should be widely available within the area as well. Consider a small stock of commonly used medications within the area to minimize trips to the pharmacy. When it comes to the COVID EU tasks, there are many processes and subtasks that will occur within the COVID EU space. Each one could be its own tutorial. I have listed here the major sub-processes that occur during the patient's healthcare journey. Let's look at these in another format called a process map. A process map literally maps all the sub-processes that occur within the area and can be thought of as a virtual walkthrough of the patient's journey, detailing each step that needs to occur in order to provide clinical care to the patient. This is an example of a process map. Each major process is shown, as well as the area it takes place in, from screening, which occurs outside the facility, to the COVID EU with all its sub-processes, and then all the way through to disposition. This process map is intended to give you a high-level overview of the processes of screening and cohorting patients. Indeed, this map could be detailed much further for the purposes of planning. For example, within triage, each step, such as checking temperature or respiratory rate, could be detailed as well. Such a detailed map would be very helpful to you when planning these processes. However, for the purposes of this tutorial, we will keep the map at a high-level overview. Within the COVID EU, triage, which we have talked about earlier, is the first step, followed by the administrative function of registering the patient. Registration should be arranged such that the patient does not contact any documents that the clerk must later handle, and a screen or window should ideally protect the clerk from droplet spread. When it comes to testing, labs and imaging, where possible, perform bedside tests and try to limit patient movement out of the unit for testing purposes. For example, rather use portable X-rays than send patients to the X-ray department. It is important to note that testing for COVID-19 by nasal or oral swab is considered an aerosol generating procedure and should occur with full PPE, including an N95 mask in a well-ventilated area, ideally a negative pressure room. When it comes to treatment, and especially with regards to resuscitation, many countries and national societies have taken a firm stance regarding CPR during the pandemic, and these local guidelines must be adhered to. But keep in mind the risk CPR poses in terms of staff exposure and take steps to keep staff protected. Minimize aerosol generating procedures. For example, MDI plus spacer use is preferred over nebulization. Intubation is also an aerosol generating procedure and full PPE is required. And finally, we arrive at disposition, at the end of the process map. Patients are either sent home to self-isolate according to local protocol or are admitted to the confirmed or suspected COVID ward or ICU. Patients may also need to be referred to a higher level of care, but as this places EMS crews and referral hospitals at risk, this should be done according to a prearranged local protocol that minimizes transfer and referral. Great job so far. We have reached the end of our tutorial. Let's summarize what we have learned. Screening directs patients into two cohorts or groups, those who are likely to have COVID and those who are less likely to have COVID. Screening and cohorting reduces spread and streamlines patient care. Screening and cohorting should be done at all facilities and at all transmission scenarios. Screening is done by applying the case definition and asking the patient a set of questions. Implementing screening and cohorting needs planning and hospital-wide buy-in. That brings our tutorial on screening and cohorting to an end. Awesome job in getting through all this information. Thank you so much for listening and join us again soon for another great AFM tutorial. You can find more tutorials like this and more AFM resources at afm.africa/resources.